How common is, I mean, it's very common, but how do they present in your practice?
So it's mostly retrosternal burning, like burning in the center
Chest
of the
pain?
chest, upper abdominal pain, and burning here.
That's the most common
Yeah,
present. Okay.
and it is a long-standing thing which helps you differentiate from a cardiac burning. So heartburn is a classical misnomer because there is no heart burning in heartburn.
Exactly.
It's
There's
a
no
food
burning
pipe
of the
burning.
heart.
Yeah.
That's
So, but you should get an ECG done in these patients.
Right.
Very important. And ask for cardiac history so that there's no angina overlapping. And a lot of these patients don't have actually acid reflux. If you look at papers from ASLD, ACG, and European organizations, that these patients, if you do a 24-hour pH metry, 2/3 of patients don't have acid reflux. It's air reflux mostly. So again, anxiety, stress, poor sleep, obesity, lack of activity, smoking, caffeine, chocolate, peppermint, all these things reduce the pressure of the lower esophageal sphincter, which is a unidirectional valve at the junction of your food pipe and your stomach. So you have to go into it, ask your patient to elevate the head end of the bed. So all of this becomes very important. So I think we have to counsel our patients in this direction.
So the one thing I tell my patient is that the GI tract is such a brilliantly created by God that every sphincter muscle has its own function. For example, we talked about defecation, right? So the internal anal sphincter should contract, the external anal sphincter should relax, and it needs to be repetitive to have a normal bowel movement. Similarly, when you are eating, the esophageal sphincter muscle, which is the sphincter muscle controlling your food pipe and the stomach, has to close after you eat.
To prevent the food from
the food from refluxing back. So to all this to happen, the brain-gut connection should work.
Yes, and see, what do you do for GERD? You actually take, so you've worked in the US, and I'm sure you know that you can't take over-the-counter PPIs or proton pump inhibitors. But in India, everyone is on PPIs.
No, even in the US, it's over the counter. It's available, yeah.
So you're killing the acid. The acid
Yeah.
is not the problem.
Right.
The acid in the wrong place is the problem. Right? So you have to understand, all of viewers have to understand, we have to discuss this, that the gastric acid is a part of our innate immunity. It prevents against the external world.
Correct.
It detoxifies a lot of things we eat. So, and it is very important in digestion and absorption of a lot of things. So if you are killing your acid, so your acid is very important for B12 absorption. It is very important for iron absorption. It is very important for calcium absorption, magnesium absorption, zinc absorption, right? Protein digestion. So it's a normal thing involved in all of this. And it is very important to prevent the term which is very popularly misused these days, SIBO. Because your small intestine is free from the small intestinal bacterial overgrowth. Anaerobes which were supposed to be in the colon are growing in the small intestine. So when you kill your acid with these over-the-counter acid suppression drugs, your small intestine starts developing anaerobes. Because that acid stimulus in the duodenum is very important for your pancreatic secretions, which are the alkaline secretions, which keep your small intestine sterile.
Right.
So again, telling everyone that killing the acid is not the answer is very important.
Right. So the acid reducers does play a role because that will help your symptoms, that will prevent further progression in case if it is acid-induced damage. But long-term usage, more than a year or two, that can cause significant amount of problems.
Yes.
So what I tell my patient is that, if the acid reducer, like omeprazole, esomeprazole, pantoprazole, whatever it is helping your symptoms.
It is suppressing your symptoms, not the disease.
Not the disease, correct. So in due course of time, if you go just manage your stress, anxiety, diet, lifestyle, you can use this as a temporary band-aid for now. And then you can have like 6 months to 1 year as a destined structure and try to improve within that. There are few patients who will need long-term PPI therapy for few indications, like, Barrett's esophagus or something, acid-induced damage to the esophagus. But majority, I agree with you that it has been used without a proper structure.
Yeah.
And long-term use of PPI can cause bad bacteria.
Postmenopausal fractures, all of this due to calcium, magnesium malabsorption, iron deficiency. Iron deficiency is such a common problem in India. It's such a common, 25% men, 57% females have iron deficiency.
We see a lot of patients with colon cancer in the US. Stomach cancer is pretty common here.
Both are common here.
Both are common.
Very common. So if you have an iron deficiency, anywhere after 40, your prescription should have an endoscopy, colonoscopy written over it.
Can you tell me a story where there is a stomach cancer that you found?
Yeah. So there was a 44-year-old, last week only, 44-year-old guy came with, hemoglobin 7-8. I did iron B12. Both were low. I told him that you need an endoscopy and a colonoscopy. Looking at your age, endoscopy becomes more important. So he said that cannot we do without a endoscopy, colonoscopy? I said medically we cannot. So if I don't write it on my prescription and tomorrow something comes out, you can bring me to the court of law and the judge will ask me, the medical board which will sit will ask me that why didn't you advise? And if I tell them that in India patients think that I'm a thief and I want to loot their money, that is why I didn't write. The court will again put me in jail. That this is not your duty to think about it. You have to be medically correct. Right? So I'm not forcing you to get it done. I'm telling you that this is class 1 indication and you should get it done. And after 10 days he came, we did an endoscopy and we found a mass in the fundus, the gastric fundus.
stomach.
The stomach, we found a mass. We did a biopsy. It was gastric adenocarcinoma. Luckily, he had a resectable disease on a PET scan. And he got operated 2 days before I came with a total gastrectomy, and I think we'll be able to save him.
Nice.
Another a very good story comes to my mind. So we're talking about blood in stools, right?
Yes.
So a friend came to me with his wife, 7 months pregnant, having blood in stools. So they said that they had seen 4 gastroenterologists, 3 gynecologists, and they said that hemorrhoids are very common in pregnancy because of constipation and all. And so just wait for 2 more months for delivery and it'll get better. They were having something or something. I just told them that, can you tell me your history? Can I just ask you your 7 red flags which I ask? So I asked for family history of disease. So she said her father had ulcerative colitis and died of CA colon cancer. So I asked her, you didn't tell anyone? She said, nobody asked me. I saw such big gastroenterologists and so many people. So I said, let's do a sigmoidoscopy. We'll give you an EMA. We'll see that area and we'll come back. It'll take 2 minutes. It'll have no effect on your pregnancy. So you're very scared, husband, wife. I told them that you can trust me.
Yeah.
You have come through a friend. We did it. It was ulcerative colitis. We started her on mesalamine, just mesalamine, with a suppository and an oral. Yesterday I got a message, it's been 1 month. We are absolutely off symptoms. What do you want? Shall we come to you? I asked them that you can wait for 1 more month. Please don't stop the medicines. Get the baby delivered. And then maybe come and see. We'll do a full length and then see what's the extent of the disease. So again, if you just talk to the patient, like Harrison preface says, talk to the patient carefully. The patient is telling you the disease.
Correct.
So it becomes very important. So these are 2 stories which come to mind when you ask.
Right.